Tanzania is a country in East Africa, very large country. Mwanza is the second largest city. You have a population of tens of millions of people in the metro area. That's where the Bugando Hospital is and the medical school. One of our big initiatives was Wild Bugando. Sandy Weil endowed a medical college.
We are thinking way beyond just school in New York State, but how we can make a difference really in the world.
To endow a medical college makes a long-term difference that just can keep growing and growing and growing. So I then asked the question, what about burns? Burns happens to children, it happens to poor people, and then the instruments aren't there, the experience isn't there, and then there's a tremendous need for everything else.
We have a lot of patients with burn injury, especially children, and most of them are due to scald injury, burn due to hot water, hot oils, and a few pediatric cases with an open frame burn injuries.
The problems with burns in Africa and the developing world in general, everywhere is resource poor is the same story. The distances are too great and the ambulances don't exist. The patients that make it to the hospital oftentimes have had their burns for quite a long time. And now they have an open wound. You survived a burn injury. You survived the pain, and it's known now by looking at it that your wound will not close without a skin graft. Or if it does close without a skin graft, it's going to be so prolonged that you end with a completely deformed hand or foot. You have to go and see. And what's motivating this project, which is unnecessary suffering, really, of children and adults with burn injury. As soon as we arrived and put our bags down, we went to the hospital. We worked at two hospitals, Sekotori Regional Referral Hospital, and then the main medical center, the Tertiary Referral Center, Bugando. This is an outreach to try and improve acute burn care. So the patients who were burned recently are going to be our patients. 2 weeks before our arrival, there had been a bad explosion. There were 4 deaths. A mother, father, 2 children died. Right away, we met the 2 of the survivors. A young boy named Charles, who was 12, and his sister Sarah, who was about 7. He was burned about 20% of his body to 3rd degree. His burns had become green with infection. He was dying. We took him to the operating room the first chance we could get, did very aggressive surgery using tourniquets which spare blood loss. This was new to our host surgeon, Dr. Gidi. We then wrapped his arms in gauze and a solution that we made from bleach from the marketplace. We weakened it tremendously. Then committed to changing his dressings day and night, twice a day, for 4 days. This surgical control, along with the dressing changes, allowed us to graft him with his own skin on the areas that had been previously infected that Friday. So Monday, the first operation, Friday. What was really remarkable was Charles, the morning after surgery, reporting himself that he felt better. In other words, that infection was removed from his body. He could feel it. He felt stronger, brighter. And so that was the day that I realized we had pulled him away from the path to death. When his dressings came down, the skin had taken 100% in the areas that had been infected. Was revolutionary to the African surgeons.
This is the new for us, that now we can do the operation fresh wound, and you do the skin grafting to the wound, and the wound will be healing.
You ask whether or not they have the ability to replicate what we were able to do with Charles. A footnote to this story is that Sarah and Charles had a younger brother who was also in the explosion that, because of language barrier and all, we didn't know he existed. After Charles and Sarah had done well with our care, the family, in the very last day that we were there, brought us this younger brother who was about 2 years old. His burns were not the kind that would kill him, but they were the kinds that would scar him terribly. I got an email from Dr. Gidi when I was back in the States that they had treated him, that they had surgically closed his wounds in a way that I know that they had never done before. Really, the problem of burn care is planetary, and there's many people that I'll never have a lifetime enough to touch. You know, when I got home, I thought, really what this is education. I'm trying to educate people about burn care. And so we realized, what is out there in terms of simulation training. So far, we have no simulation of burns available to young surgeons who want to acquire burn skills.
You want to keep everything in field?
Here at Weill Cornell Medical College, we have a surgical simulation lab. The director, Elliot Silverman, and he and I together, and Dr. Yurt, our director here, is working on the project to break burn surgery into its pieces, figure out how to make it in the simulation lab. It's best to start so that in the future, I'll be taking a young resident who's about to come on the burn service, tell him a month before he comes, you go to the simulation lab, you get to a certain level of proficiency, then we'll work together.
This will help develop tangential excision skills.
This is a ripe ground both for our own residents and to export as we do this international outreach and leave them with simulation so that they can practice and teach and propagate.